Okay, today we'll discuss the valvular guidelines 2021. The agenda of today will go through the different topics of patient evaluation, management of different valvular lesions, prosthetic valves, management of antithrombotics, and management of associated conditions, example, coronary artery disease, atrial fibrillation, and special situation as pregnancy. First, there was a focus on the patient-centered evaluation for intervention, including the importance of the presence of a heart valve center of excellence in the treatment of valvular heart disease, in which the decision-making passes through two main stages. The first stage is the stage of clinical and imaging assessment of the patient, including symptoms, whether it's related or not to the valvular heart disease, etiology, mechanisms of valvular heart disease, severity, and life expectancy of the patients. With interpretation of these data, we go to the second stage, which is the heart team evaluation, evaluating the resources, the options, weighing the benefit versus the risks, the patient's preferences, and eventually reaching to a final team decision. There was also a focus from the guidelines on the importance of early intervention in patients with severe valvular heart disease who are asymptomatic. In this case, we should weigh the risk of early intervention regarding the procedural complications and late complications versus the risk of delaying the intervention, example, the irreversible damage that may occur to the left ventricular function. To answer this question, we have to view the patient from different perspectives, including the type of valvular heart disease, type of intervention, the age of the patient, comorbidities, and general condition. First, the aortic valve disease management. First, the aortic regurgitation, severe aortic regurgitation. As we know, the assessment of severity of aortic regurgitation depends on several parameters, qualitative, semi-quantitative, and quantitative. The indications of intervention or surgery in patients with asymptomatic severe aortic regurgitation is the presence of left ventricular end systolic diameter of more than 50 millimeter or more than 25 millimeter per meter square body surface area, or resting left ventricular ejection fraction less than or equal 50%. This is a +1 indication. And they added a new recommendation that if the LV end systolic diameter more than 20 millimeter per meter square body surface area, or resting left ventricular ejection fraction less than or equal 55, then and the patient is at low surgical risk, then surgery may be considered class B. As we can see, there is a tendency towards earlier intervention. In case of symptomatic severe aortic regurgitation, of course, it's class 1 indication for surgery regardless of the LV function, and aortic valve repair may be considered in selected patients at experienced center. What about intervention in patients with aortic root or tubular ascending aortic aneurysm? Regardless of the severity of aortic incompetence, they used the term valve sparing aortic root replacement is recommended in young patients with aortic root dilatation if performed in experienced center. This is class 1 recommendation to spare the valve. The indications for intervention in patients with aortic root dilatation in Marfan or bicuspid or Loeys-Dietz are the same as previously mentioned in guidelines 2017. I will go rapidly through the indications which have a new recommendation. So we'll go now to the aortic stenosis. Of course, aortic stenosis evaluation through thorough echocardiographic examination is important because we have different types of severe aortic stenosis. We have the high gradient aortic stenosis, Vmax more than 4 meters per second and mean gradient more than 40 millimeters per second. We have the low flow, low gradient aortic stenosis, which have its algorithm in management, in diagnosis and management. Regarding the recommendation for intervention in patients with asymptomatic severe aortic stenosis, it's recommended to have surgery if LV dysfunction occurred, ejection fraction less than 50 without another cause, and it's recommended to have surgery in asymptomatic patient if they demonstrated symptoms on exercise testing class 1 indication. They added in the new guidelines a recommendation that intervention should be considered in asymptomatic patients with severe aortic stenosis and LV dysfunction, ejection fraction less than 55 without another cause. And that was based on the results of this trial. This was a multi-center randomized trial that compared early surgery versus conservative care in patients who had very severe aortic stenosis. They were 145 patients, and the result was that the operative mortality or death from cardiovascular disease was significantly lower in the patients who had early surgery versus the patients who had watchful waiting conservative care. Also, from this study, which was published in 2019, which compared the effect of left ventricular, or the correlation between the left ventricular ejection fraction versus the survival percentage in patients with severe asymptomatic aortic stenosis. And it showed that the left ventricular ejection fraction less than 55, represented by the blue line, showed significantly lower survival rates if compared with left ventricular ejection fraction above 55%. Then we resume the indications for intervention in patients with severe aortic stenosis who are asymptomatic. We find it should be considered in patients who had a sustained fall in blood pressure more than 20 millimeter mercury during exercise testing. And if asymptomatic with LV ejection fraction more than 55 and the normal test, but they have a procedural risk low, and one of the following, it should be considered, they should be considered to have intervention if they have very severe aortic stenosis, mean gradient more than or equal 60, or Vmax more than 5 meters per second. The Vmax has changed. Previously it was 5.5 meters per second. Now it's 5 meters per second to identify the very severe aortic stenosis. The rate of progression of severity of valve calcification of more than or equal 0.3 meter per second per year, and markedly elevated BMP levels more than 3 times the age and sex correlated normal range. Regarding management of symptomatic severe aortic stenosis, as we said, it depends on identification of the type of aortic stenosis. In cases of high gradient aortic stenosis on the right side of the algorithm, it's class 1 to have surgery in patients who are symptomatic severe aortic stenosis. The same applies for the extreme left of the algorithm in patients with low gradient aortic stenosis who have low stroke volume index and low ejection fraction less than 50, who underwent dobutamine stress and showed that they have a flow reserve. This severe symptomatic aortic stenosis is class 1 indication for surgery. Whereas patients who have low flow, low gradient aortic stenosis with low stroke volume index, but normal ejection fraction more than 50, which we call paradoxical aortic stenosis, this needs an integrated approach using the coronary calcium score system to identify if this patient has really severe aortic stenosis through the identification of heavy calcification. This patient, if was proved to have severe aortic stenosis by calcium CT, is class 2A indication for intervention. And the same applies for patients who were low flow, low gradient aortic stenosis with left ventricular ejection fraction less than 50, but they demonstrated no flow reserve on the dobutamine stress echo. Again, an integrated approach is needed, and if proved severe by CT, these patients are indicated to have surgery class 2A. What about the mode of intervention in aortic stenosis? The guidelines stressed on the idea of the heart valve center, again, as I mentioned earlier. It's class 1 recommendation to evaluate the patient clinical, anatomical, and procedural factors that will direct me to choose either TAVI or surgical aortic valve replacement. Many studies have been conducted since 2011 to test TAVI versus surgical aortic valve replacement regarding the effect on mortality over 5-year follow-up period. The Partner 1A and the US core valve tested high-risk patients. The Partner 2 TAVI and Notion tested intermediate risk patients, and the still ongoing Partner 3 and Evolute low-risk trials are testing now the low-risk patients. The results that we have from the studies on high and intermediate risk population, the 5-year outcome proved that the TAVI was non-inferior to surgical aortic valve replacement. We are still waiting for the results, 5-year follow-up results of Evolute and Partner 3, which were conducted in 2019. The Evolute Low Risk is studying now the self-expanding valve in low-risk patients, and the Partner 3 trial is studying the balloon expandable valve in low-risk patients. Interestingly, we find that the 2-year outcome of the Partner 3 trial showed that TAVI is even more superior than surgical aortic valve replacement with a p-value 0.007. But this result can be attributed to the inclusion and exclusion criteria. In this trial, there were very highly selected patients with only high flow aortic stenosis, low flow were not included. Very low risk patients, STS is 2 in the inclusion criteria, transfemoral access only, mean age 73, and males. What are the recommendations to choose whether TAVI or surgical aortic valve replacement? It's a class 1 recommendation for TAVI if the patient is above 75 years or unsuitable or high risk for surgical aortic valve replacement with STS score or EUROS score more than 8 and suitable for transfemoral TAVI. On the other hand, we find that patients who are less than 75 years and at low risk for surgical aortic valve replacement with EUROS score less than 4% or unsuitable for transfemoral TAVI and operable, it's class 1 to have surgical aortic valve replacement. Otherwise, it's class 1 to approach the patient through heart team discussion and evaluation of the clinical and anatomical factor to guide the therapy towards either TAVI or surgical aortic valve replacement. These are the 3 recommendations that I just mentioned, class 1 recommendations. A new recommendation was added regarding the non-transfemoral TAVI access. It may be considered in patients who are inoperable and unsuitable for transfemoral TAVI. And balloon aortic valvotomy may be considered as a bridge to surgical or TAVI aortic valve replacement in hemodynamically unstable patients and in those with severe aortic stenosis who require urgent high-risk non-cardiac surgery. I will rapidly go through the main clinical and anatomic characteristics that would favor TAVI or favor surgical aortic valve replacement. Regarding the clinical, if we have an elderly patient, if we have a patient who underwent CABG before, if we have frail patient that goes with TAVI more than surgical aortic valve replacement, if we have sequelae of chest radiation or porcelain aorta or high likelihood of severe patient prosthesis mismatch, this favors more TAVI. If we have chest deformity, this favors TAVI. However, if we have bicuspid aortic valve with aortic root disease, it favors more the surgical type. If we have valve morphology unfavorable for TAVI or thrombus in the aorta or the left ventricle, it favors surgical. And if you have a concomitant indication of intervention and another valve that requires open heart surgery, this favors surgical aortic valve replacement, as appearing here in this recommendation regarding CABG or surgical intervention on the ascending aorta or another valve. If there is an indication, primary indication for CABG or surgical intervention, then it's class 1 to have surgical rather than TAVI, surgical aortic valve replacement. And if the aortic stenosis is not severe, it's just moderate, it's class 2A to have surgical aortic valve replacement. What about mitral regurgitation? First, it's very important to detect the mitral regurgitation etiology, whether it's primary or secondary. And we know that the secondary mitral regurg, especially the ischemic type, has worse outcome, worse survival. As we said in the aortic regurgitation, the assessment of the mitral regurgitation depends on many parameters: qualitative, semi-quantitative, quantitative, and structural. And to differentiate between the primary and secondary mitral regurgitation, we also have different parameters. I will focus on the EROA, the effective regurgitant orifice area, as a cutoff value to differentiate, to diagnose primary or secondary mitral regurgitation. In the previous guidelines, it was 40 millimeters for primary and 20 millimeters for secondary. In the new guidelines, it's now above 40 millimeters square and maybe more than or equal 30 millimeters square if elliptical regurgitant orifice area is present. And that was after the results of the POAP trial, which I will discuss few minutes from now. What are the indications of intervention in patients with severe primary mitral regurgitation? It's +1 recommendation that we get mitral valve repair if the results are expected to be durable in a center of expertise. And it's also class 1 recommendation if the patient is asymptomatic, severe primary mitral regurgitation with LV dysfunction, left ventricular end systolic diameter of more than or equal 40 millimeters and or ejection fraction less than or equal 60%. This cutoff value was changed. It was previously 45 millimeter for the end systolic diameter. Now it's 40. Another indication for intervention in asymptomatic patients is the presence of atrial fibrillation secondary to mitral regurgitation or pulmonary hypertension more than 50 millimeter mercury. If the patient has normal ejection fraction more than 60 and normal LV and systolic diameter less than 40 and none of the atrial fibrillation or pulmonary hypertension, we should look at the left atrial dilatation. If he has a significant left atrial dilatation and the patient is low risk for surgery, it's class 2A to have surgical mitral valve repair. Why did they change the cutoff value to 40 and why did they include the presence of atrial fibrillation and systolic, RV systolic pressure and ejection fraction less than 60? Because in the MEDA mortality risk score, the mitral regurgitation international database, they developed a prognostic model for the detection of early and late death in degenerative mitral regurgitation. And they found that these parameters were associated with a worse outcome. That's why they were included in the recommendation in asymptomatic patients. Regarding the mitral valve repair, we know that recurrence of mitral regurgitation following mitral valve repair is associated with worse outcomes if compared to no mitral regurgitation following mitral valve repair. And that's why it's class 1 recommendation only if in a center of experience. What about the management of severe chronic primary mitral regurgitation? We already mentioned the asymptomatic arm on the left side, so we'll go through the symptomatic arm on the right side of the algorithm. Simply if the patient is symptomatic and he is at high surgical risk or it is at low surgical risk is the dependent question. If the patient is symptomatic and he is at low surgical risk, then surgery, preferable repair is class 1 recommendation. If the patient has high surgical risk, then edge-to-edge repair may be considered as class 2B if anatomically suitable, of course, with heart failure treatment. Now we finish the primary mitral regurgitation and we go to the secondary mitral regurgitation. And here we have to mention the results of the Mitral FR trial and the COAP trial. Both trials were done on patients who had secondary mitral regurgitation. They used the mitral clip device to do the edge-to-edge repair, but the results of the two trials were not the same. In the Mitral FR trial, the intervention group had no significant difference from the control group as regards the probability of freedom from an event. However, in the COAP trial, the intervention group represented in the blue line, the device group had a significantly lower event rates in the form of all-cause mortality or heart failure hospitalization with p-value less than 0.001. Why there was a difference in the results of both trials? Because the patients in the COAP trial were very highly selected. Patients who had stage D heart failure were excluded. Patients with left ventricular end systolic diameter more than 70 were excluded. Patients with right-sided congestive heart failure with moderate or severe right ventricular dysfunction were excluded. Tricuspid valve disease requiring surgery excluded. Pulmonary arch systolic pressure more than 70 non-responding to vasodilator excluded. All these parameters were not for sure excluded in case of Mitral FR. Another difference between the two trials is the EROA. In the Mitral FR trial represented by the orange bar, we find that 52% of patients had an EROA of less than 30 millimeters square, whereas in the COAP trial represented by the blue bar, 41% of patients had an EROA of more than 40 millimeters square. So more patients with more severe mitral regurg were included in the COAPT trial. So we expected more benefit from the edge-to-edge repair. And that's why the cutoff value for secondary mitral regurgitation changed to 40 millimeters square. Regarding the management of secondary mitral regurgitation, it's a multidisciplinary approach. Secondary mitral regurgitation, we should first target the primary disease. So first, we should apply the guideline-directed medical therapy, including CRT implantation if indicated. If the patient is expected to have a life expectancy more than 1 year, we should go and search for a baseline disease as coronary artery disease or other cardiac disease requiring treatment. If we fail to find any other underlying disease that requires treatment and the patient is still having severe symptoms, then we go for assessment of the patient if he is appropriate for surgery or not. If he is appropriate for surgery, it's class 1 to have mitral valve surgery, and this is a new recommendation. If the patient was not appropriate for surgery in the absence of end-stage left ventricular or RV failure, then we see if the patient is fulfilling the criteria that we just mentioned in the COAPT trial with increased chance of responding to edge-to-edge repair. If this is the case, then edge-to-edge repair is class 2A indication. If this is not the case and the patient does not fulfill the criteria, then edge-to-edge repair may be considered as a class 2B after careful evaluation for LVAD or heart transplant. This is regarding if the patient does not have coronary artery disease or a cardiac disease that needs treatment. What if he has? If he has, then we should assess if the patient can undergo this surgery. If he can, then combined CABG or the other cardiac surgery with mitral valve surgery is class 1 recommendation. What if the patient is not fit for surgery and he needs treatment of his underlying disease? Then catheter-based approach is used, either PCI or TAVI. And reassessment of the patient's symptoms. If he's still persistently symptomatic despite this catheter intervention, then the patient class 2A to have edge-to-edge repair, and this is a new recommendation. As we see here, this is the new recommendation if the patient was symptomatic despite optimal medical treatment, class 1 indication to undergo valve surgery for secondary severe mitral regurgitation. And we see here that the patient who have concomitant coronary artery disease or cardiac disease requiring treatment is class 1 for surgery, and class 2A if he is not fit for surgery to do PCI and or TAVI, and possibly followed by edge-to-edge repair. And this is, as I said, a new recommendation. Patient without concomitant coronary artery disease, again, edge-to-edge repair, it's class 2A if I find the criteria fulfilling the inclusion criteria found in the COAPT trial. If not, then it's class 2B to have edge-to-edge repair after evaluation of the patient. I will go rapidly through the mitral stenosis, again, focusing on when to operate or when to intervene in patients with asymptomatic, clinically significant mitral stenosis with mitral valve area less than or equal 1.5. It's class 2A to do percutaneous mitral hysterectomy in those patients in case with no unfavorable clinical and anatomical characteristics and 1 or 2 of the following, either high thromboembolic risk as history of systemic embolization or high risk of hemodynamic decompensation as in cases of high pulmonary artery pressure more than 50 at rest, or desire for pregnancy. What are the unfavorable clinical and anatomical characteristics? The clinical are the old age, history of commissurotomy previously, NIHA class 4, permanent AF and severe pulmonary hypertension, and anatomical unfavorable characteristics are echo score more than 8, Cormier score 3, severe TR, very small mitral valve area. And of course, the eliciting of symptoms on exercise testing is another indication to intervene in asymptomatic patients. So we are done with the left side of the algorithm. Now we go rapidly through the symptomatic severe mitral stenosis in the right side of the algorithm. We have to know that the favored intervention is the percutaneous balloon mitral commissurotomy. It's class 1 indication, especially in case of contraindication or high-risk surgery. In the presence of contraindication to balloon mitral commissurotomy, it's class 1 to perform surgery. And the contraindications are represented in the red box here, including left atrial thrombus, more than mild mitral regurgitation, severe or bicommissural calcification, absence of commissural fusion, as in cases of mitral annular calcification, also known as degenerative mitral stenosis. There is no commissural fusion in these patients. And of course, the presence of a concomitant valvular disease or coronary artery disease that requires surgery. Tricuspid valve disease, asymptomatic patients with severe primary tricuspid regurgitation should be considered for surgery in the presence of RV dilatation, and this is class 2A. Regarding the treatment plan of primary tricuspid regurgitation, primary severe tricuspid regurgitation, the first question to be answered, if there is a need for left-sided valve surgery or not. If we have an indication for left-sided valve surgery, then it's class 1 indication in the presence of severe primary tricuspid regurg to undergo tricuspid valve repair or replacement. If it is not severe, it's mild to moderate, then we should look at the tricuspid annulus. If it is dilated, it's class 2A to undergo surgery. What if there is no need for left-sided valve surgery? So, and we have severe primary tricuspid regurgitation, we should search for symptoms or RV dilatation. If either is present, then it's indicated as class 1 and class 2A recommendation respectively. Regarding the treatment of secondary tricuspid regurgitation, it's more or less like the primary tricuspid regurgitation, severe primary tricuspid regurgitation. In case of need for left-sided valve surgery represented in the red color, surgery is recommended as class 1 in severe secondary tricuspid regurgitation. And in case of mild to moderate secondary tricuspid regurgitation, if associated with a dilated annulus more than or equal 40 millimeter, it's class 2A. In the absence of need for left-sided valve surgery, surgery for tricuspid valve is indicated in patients who are symptomatic or have RV dilatation in absence of severe RV or LV dysfunction. They added a new recommendation regarding the transcatheter treatment of symptomatic secondary severe tricuspid regurgitation. It may be considered if the patient is inoperable, it's class 2B. Tricuspid stenosis, severe tricuspid stenosis defined as mean gradient more than or equal 5 millimeter mercury is indication for surgery in symptomatic patient or in patient with indication for left side valve intervention. Small notes on combined and multiple valve lesions. As we know, many patients present to us with more than one valvular affection. In this case, we should know that there are interactions between different valvular lesions. For example, mitral regurgitation can underestimate the aortic stenosis. And in this case, we should combine different measurements to identify the severity of the lesions, especially the load-independent parameters as the valve area. In this case of multiple valve affection, indications of intervention does not primarily depend on the severity, on the mere severity of the lesions, but rather on the symptoms and the presence of LV remodeling signs. That's why we pointed out in the beginning that the heart theme discussion is very important in such cases. Regarding prosthetic valves, I'll go quickly through the indications of mechanical versus biological prosthesis. As we know, it's recommended as first class recommendation that it's according to the desire of the informed patient after informing him about the profile of each prosthesis. Regarding mechanical prosthesis, it's recommended if I'm expecting that the patient is at risk of accelerated structural valvular dysfunction, as in case of young age, less than 40 years, hyperparathyroidism, and patients on hemodialysis. If a patient is already on anticoagulation due to another mechanical prosthesis, it's class 2A to have a mechanical prosthesis. If the patient age is less than 60 for the aortic position and less than 65 for the mitral position, it's an indication for mechanical prosthesis class 2A. If the patient has a reasonable life expectancy for whom future redo valve surgery or TAVI would be at high risk, it's reasonable to give him a mechanical prosthesis rather than bioprosthesis. What about the biprosthesis? It's class 1 recommendation to implant a biological prosthesis in patients where good quality anticoagulation is unlikely, either due to adherence problems or the patient, the anticoagulation it's not readily available, or it's contraindicated due to because of high bleeding risk, or in those patients whose life expectancy is expected to be lower than the presumed durability of biprosthesis. This recommendation was revised and upgraded from 2A to class 1 recommendation for implantation of biological prosthesis. If the patient experienced a mechanical valve thrombosis despite adequate anticoagulants, the patient is indicated as class 1 recommendation to have a biprosthesis. If she is a female who is contemplating pregnancy, it's class 2A to consider biprosthesis, and relatively older age, above 65 in the aortic and above 60 in the mitral, is recommendation for biprosthesis class 2A. In the biprosthesis also recommendation, they added a new recommendation that if the patient is already on NOACs, a biprosthesis is may be considered due to the high risk of thromboembolism. Regarding the antithrombotic management, first we'll start with the management of patients with surgical valve replacements. Of course, we know that oral anticoagulant using a VKA is the standard therapy for the patients who have mechanical prosthesis, with the target INR depending on two main factors. Factor number 1 is the prosthesis thrombogenicity. As we know that different valves had different degree of thrombogenicity. The most commonly used, the St. Jude, has a low thrombogenicity. The other factor is the patient-related risk factors, the presence of one or more of risk factors, which I will mention now, makes us directed towards the higher targeted INR. These risk factors include mitral or tricuspid valve replacement, previous thromboembolism, atrial fibrillation, mitral stenosis of any degree, and ejection fraction less than 35%. As a quick reminder of the management of bleeding associated with oral anticoagulation, if we are having an INR more than 4.5 with major bleeding or need for urgent surgery, we have to stop VKA, give 10 milligram vitamin K slow IV infusion that can be repeated every 12 hours. Prothrombin complex concentrate or fresh frozen plasma should be initiated, and recheck INR after 30 minutes, then every 4 to 6 hours. In case of INR more than 10, but the patient is asymptomatic, we have to stop VKA, give 2.5 to 5 milligram oral vitamin K with daily check of INR for 2 weeks. If the INR is from 4.5 to 10 and he is asymptomatic, we stop VKA plus or minus adding oral vitamin K 1 to 2 milligrams, small dose. If the INR is less than 4.5, careful down titration or skipping doses is sufficient, and VKA should be resumed once INR is in the therapeutic range and the bleeding has stopped. Continuing the indication for antithrombotics, oral anticoagulation is recommended after implantation of a surgical biological heart valve if the patient already has an indication for anticoagulation, and this is class 1. NOACs should be considered over vitamin K antagonist after 3 months following surgical implantation of a biological heart valve in patients with atrial fibrillation. This is a new recommendation, which was based on the RIVER trial. In the RIVER trial, patients who had atrial fibrillation and a bioprosthetic mitral valve were studied to have either rivaroxaban 20 milligram once daily versus warfarin with a target INR 2 to 3. The result was that rivaroxaban was non-inferior to warfarin with p-value for non-inferiority less than 0.001. So NOACs, as we said, should be considered in patients with atrial fibrillation having a biological heart valve implantation after 3 months. This is class 2A because 80% of the patients included in the RIVER trial were included after 3 months of biological valve implantation. And it's class 2B within the 3 months following surgical implantation to give NOACs because only 20% of the patients had enrolled in this study in the RIVER trial were during the first month following implantation. What about the mitral position without atrial fibrillation? Oral anticoagulation using a VKA is recommended, should be considered for the first 3 months, mitral or tricuspid position. What about the aortic biological heart valve? In patients with no baseline indication for oral anticoagulation, a low dose aspirin 75 to 100 milligram per day or an oral anticoagulant using a VKA should be considered for the first 3 months after surgical implantation of an aortic biological valve. And this is another new recommendation, and it was based on this trial, which studied warfarin versus aspirin in patients who had a bioprosthetic aortic valve implantation, and it showed that there was no significant difference between the two drugs regarding thromboembolic complications. That's why they can be both given. It's class 2A recommendation in the aortic position. What if the patient on VKA and had a thromboembolic event despite adequate INR? It's class 2A recommendation to add a low dose aspirin 75 to 100 milligram following the thromboembolic event. And of course, as we know, NOACs are contraindicated in mechanical prosthesis. Now we go to antithrombotic management after surgical valve repair. In case of mitral and tricuspid repair, it's the same as mitral and tricuspid bioprosthesis, oral anticoagulation with a VKA during the first 3 months. In case with valve sparing aortic surgery, it's almost also similar to the aortic bioprosthesis in the indication of low dose aspirin 75 to 100 milligram, but without the option of oral anticoagulation, just single antiplatelet for 3 months. What about TAVI? Following TAVI, if the patient is having an indication for oral anticoagulation, it's class 1 recommendation to give oral anticoagulant for life following TAVI. If the patient does not have an indication for oral anticoagulant, then a lifelong single antiplatelet is the recommended regimen after TAVI. And of course, routine use of oral anticoagulant is not recommended. These are new guidelines, and they are based on the following trials. In the popular TAVI cohort B trial, oral anticoagulant, either VKA or NOAC, was studied versus oral anticoagulant plus clopidogrel. And in this study, there was significantly higher bleeding events at 12 months in the group of people who received oral anticoagulant plus clopidogrel. Another trial, the popular TAVI cohort A trial, studied aspirin versus dual antiplatelet, aspirin plus clopidogrel following TAVI, and there was significantly higher bleeding events in case of dual antiplatelet if compared to aspirin alone. Also, rivaroxaban added to aspirin was studied versus dual antiplatelet, and they both had increased rates of major bleeding and death and thromboembolism. That's why, again, this is a conclusion of what I was saying about antithrombotic for valve prosthesis. The mechanical heart valve is straightforward, it's VKA for life. The bioprosthetic valve, we have first to answer the first question. If he has an already present indication for oral anticoagulation, then oral anticoagulant is class 1 indication for life. If the patient doesn't have an indication for oral anticoagulation, then it depends on the position of the bioprosthesis. If you are talking about the mitral or tricuspid bioprosthesis, then oral anticoagulation for 3 months is recommended, or it should be considered. If you are talking about surgical aortic valve replacement, then either single antiplatelet or oral anticoagulant for 3 months should be considered. If you are talking about TAVI, then single antiplatelet for life is recommended as class 1. What about the perioperative management of antithrombotics? It's class 1 recommendation to stop VKA before elective surgery, aiming at an INR of less than 1.5. And it's important to make bridging of oral anticoagulation when we stop the VKA in the following conditions. If the patient has mechanical prosthetic valve, atrial fibrillation with significant mitral stenosis, atrial fibrillation with CHA2DS2-VASc score more than or equal 3 for women and 2 for men, acute thrombotic event within previous 4 weeks, high acute thromboembolic risk. In this case of bridging, we should use the low molecular weight heparin is the recommended, or unfractionated heparin for bridging. And first day post-operative, we should resume vitamin K antagonist together with low molecular weight heparin or unfractionated heparin. It's class 1 recommendation that if the patient was indicated for aspirin, that he continues on aspirin peri-procedural period. This is class 1 recommendation, and this is a new recommendation. If the patient had a recent primary PCI and the patient is indicated for dual antiplatelet within 1 month, and we had to stop the P2Y12, it's indicated that post-surgery resume the P2Y12 inhibitor as soon as possible. If the patient during the stoppage of P2Y12 and we need to cover or bridge this therapy, we can use or we may use the glycoprotein 2B3A inhibitor or canglilol as a class 2B recommendation for bridging, and it's another new recommendation. Regarding the recommendation for antithrombotics with a concomitant antiplatelet therapy, these recommendations are not totally new. They were discussed before in the non-STEMI and in atrial fibrillation guidelines, but they are newly added to the valvular guidelines, which state that according to the thrombotic versus the bleeding risk of the patient, if I have a high thrombotic risk and there is an indication for triple therapy, then triple therapy can continue to up to 1 month. If I have a low thrombotic, if I have a slow thrombotic risk and a high concerns about high bleeding risk, aspirin can be stopped up to 1 week and continue on oral anticoagulant and P2Y12 for 6 or 12 months according to the concerns about bleeding or thrombosis. The discontinuation of antiplatelet after 12 months is class 1 of it's class 1 recommendation in patients who are on triple or dual antiplatelet to remain only on oral anticoagulation after 12 months. What about the target INR in the case of dual or triple therapy? Dual antiplatelet or triple antiplatelet plus oral anticoagulant, it's recommended that the target INR is towards the lower part of the recommended target and a time in the therapeutic range to be more than 65 to 70%. Short notes on prosthetic valve dysfunction. The first complication is the mechanical prosthetic thrombosis. We have a class 1 recommendation in critically ill patients without serious comorbidity to undergo urgent or emergent valve replacement. We have a class 2A recommendation for fibrinolysis if the patient is at high risk for surgery or if the thrombosis occurred on the right side prosthesis. And surgery should be considered for large, more than 10 millimeter non-obstructive prosthetic thrombus complicated by embolism. In case of bioprosthesis thrombosis, anticoagulation using a VKA or unfractionated heparin is class 1 recommendation in bioprosthetic valve thrombosis before considering reintervention. And we have a new recommendation regarding leaflet thickening, or the term HOLT, which is hypoattenuated leaflet thickening that's commonly found in patients post-TAVI. If this leaflet thickening and reduced leaflet motion is detected, leading to elevated gradients, it's recommended or should be considered to add anticoagulation at least until resolution. This new recommendation was based on this trial, the Galileo 4D trial, which compared the effect of rivaroxaban 10 milligram with aspirin versus aspirin and clopidogrel and their effect on leaflet motion reduction. We found that greater reduction was observed with the rivaroxaban arm and not found in the dual antiplatelet arm. That's why the patients are indicated for anticoagulation. What about the hemolysis and paravalvular leak? Reoperation is recommended as class 1 in the presence of endocarditis, hemolysis requiring repeated blood transfusion or leading to severe heart failure symptoms. And transcatheter approach, transcatheter closure should be considered if the patient have a prohibitive risk. Decision on whether to choose the transcatheter or the surgical approach, of course, it depends on patient risk, leak morphology, and local expertise, and this is a new recommendation. Bioprosthetic failure recommendation, reoperation is recommended if the patient is symptomatic as a class 1 indication in the presence of significant increase in gradient, prosthetic gradient, And if the operation becomes class 2A if the patient is asymptomatic in the presence of significant increased gradient and if reoperation is at low risk. Transcatheter transfemoral valve-in-valve implantation in the aortic position is class 2A after heart team discussion. Transcatheter valve-in-valve implantation in the mitral or tricuspid position is class 2B recommendation. And this is a new recommendation too. What about the recommendation of management of atrial fibrillation in patients with native valvular heart disease? For stroke prevention, atrial fibrillation patients who are eligible for oral anticoagulation, it's preferred to have NOACs in preference to VPA in patients with aortic stenosis, aortic and mitral regurgitation. And that was upgraded recommendation based on subgroup analysis of the major landmark trials of the different NOACs, which proved that their beneficial effects regarding stroke prevention were similar between the valvular heart disease group versus the non-valvular heart disease group. That's why it's class 1 recommendation. We have the surgical interventions. Concomitant atrial fibrillation ablation should be considered in patients undergoing valve surgery, and left atrial appendage occlusion should be considered class 2A to reduce the thromboembolic risk in patients with AF and CHA2DS2-VASc more than or equal to undergoing valve surgery. And this new recommendation or upgraded recommendation was after the release of this trial, which compared patients who were undergoing cardiac surgery. Half of the patient underwent concomitant left atrial appendage occlusion and half of the patient didn't. And we found that there was a significant reduction in the risk of ischemic stroke or systemic embolization in the patient who underwent left atrial appendage occlusion. That's why it was upgraded. What about management of coronary artery disease in patients with valvular heart disease? We know that coronary angiography is recommended in patients before valve surgery, in patients with severe valvular heart disease, and one of the following: history of cardiovascular disease, suspected ischemia as the presence of chest pain, left ventricular systolic dysfunction in men above 40 and postmenopausal women, and in the presence of one or more cardiovascular risk factors. Coronary angiography, as we know, is class 1 recommendation in the presence of severe secondary mitral regurgitation, and coronary CT angiography can be an alternative to coronary angiography before valve surgery in patients with severe valvular heart disease and low probability of coronary artery disease. Also, it can be a good option in case of emergency surgery with patients with acute infective endocarditis with large vegetations protruding in front of a coronary ostium. What about indications for myocardial revascularization in patients with valvular heart disease? If there is a primary indication for aortic, mitral, or tricuspid valve, together with a coronary artery diameter stenosis of more than or equal 70, class 1 indication to perform CABG for this stenosis together with the valve surgery. If the stenosis is from 50 to 70, CABG in this case is class 2A. What if the patient primary indication was to undergo TAVI? Then if we have a concomitant coronary artery stenosis of more than 70 in a proximal segment, PCI is class 2A. If the transcatheter mitral valve intervention is the primary indication for intervention, for catheter-based intervention, a concomitant PCI should be considered if we have a stenosis, again, more than 70 in the proximal segment. Short notes on valvular heart disease with pregnancy. Pregnancy should be discouraged in the following situations: patients with mitral stenosis and valve area less than 1.5 centimeters square, because if these patients got pregnant, the pregnancy is poorly tolerated and will probably need a percutaneous balloon mitral commissurotomy after 20 weeks gestation. If the patient has severe aortic stenosis plus symptoms, or severe aortic stenosis who are asymptomatic with impaired ejection fraction less than 50, or severe asymptomatic aortic stenosis with an abnormal exercise test. And of course, Marfan syndrome with an aortic diameter more than 45 because risk of aortic dissection. And in the setting of bicuspid valve, if the aortic diameter is more than 50, or if the aortic diameter is more than 25 millimeter per meter square in Turner, and in all patients with vascular Ehlers-Danlos syndrome. When to say that CS is recommended in valvular heart disease patients in case with severe mitral or aortic stenosis, in case of ascending aortic diameter more than 45 millimeter, in case of severe pulmonary hypertension, and if the delivery had to be done while the patient is already treated with a VKA or before passing 2 weeks after discontinuation of a VKA. I will say quickly short notes on medical treatment. We shouldn't forget prevention for rheumatic fever in patients who had aromatic etiology. We shouldn't forget the endocarditis prophylaxis in cases of prosthetic valve or use of prosthetic material in repair. And serial follow-up for the patient should be every 6 months in severe asymptomatic cases, every 1 year in moderate cases, and 2 to 3 years in mild cases. In case of aortic regurgitation, ACE inhibitors can be used to provide symptom improvement in patients who continue to suffer from heart failure or hypertension post-surgery. In patients with Marfan, of course, beta blocker is the mainstay of treatment to reduce the shear stress. In case of aortic stenosis, there is no medical therapy that will decrease the progression of the disease, as the statins were studied in this perspective and they didn't prove to affect disease progression. Patients with heart failure waiting or unsuitable for surgery, they should take the guideline-directed medical therapy. ACE inhibitors are safe as long as blood pressure is monitored carefully. Blood pressure should be monitored, should be controlled to avoid added afterload, but with caution, titration of vasodilators to avoid symptomatic hypotension. In mitral regurgitation, nitrates and diuretics reduce the filling pressure. Inotropes and intra-aortic balloon can be used in cases of hemodynamic instability. In mitral stenosis, diuretics, beta blocker, digoxin, non-dihydropyridine calcium channel, and ivabradine improve the symptoms. In case of sinus rhythm, mitral stenosis, indication of oral anticoagulation, it's recommended as class 1 if there is a history of systemic embolization or left atrial thrombus, and it should be considered as a class 2A in case of dense spontaneous echo contrast shadow by TE or left atrial enlargement more than 50 millimeter or left atrial volume index more than 60 milli per meter square. Thank you.
اكسلنت يا جولييت. الحقيقه انت قلتي 10 محاضرات في المحاضره، دول 10 محاضرات يعني mitral regurgitation, mitral stenosis والترايكاسبيد واورتيك ادي 6، وانتي ثرومبوتيك ثيرابي 7، وبروثيتيك فالفز 8، والكومبليكيشنز، وبعد كده الميديكال. يعني انت قلتي فعلا 10 محاضرات، يعني دول كل واحده من دول محتاجه محاضره كامله. فانا بحييكي على المجهود الكبير وعلى البرزنتيشن الرائع ده.
وبالتالي انا نفس الكومنت بتاعي. مساء الخير يا مجدي. نفس الكومنت كنت عايز اقول لها يا جولييت، المفروض المحاضره دي هي تتوزع على محاضرتين 3 عشان نلحق يعني نكمل هائل من النولج ده نستوعبه الحقيقه.
ما انا عشان كده يا دكتور محمد، انا دلوقتي بعد الكم الهائل من الداتا الجديده دي والحاجات الكتيره اللي اتقالت، انا فكرت ان هي ان شاء الله على مرتين جايين هنحضر مجموعه من الاسئله، يعني هتتقال بقى بطريقه مختلفه، يعني زي كده شورت كيس كده على كل ريكومنديشنز. مثلا فور اكزامبل، مثلا عيان عمل تافي فور نوواكس ولا فور اورال انتيكوجوليشن ولا فور انتي بليتلتس، وبعد كده هي تعرض لنا على طول الجايد لاينز وهكذا، يعني زي كيس اكزامبلز تو كفر الجايد لاينز بطريقه
داتا رهيبه جدا. ممكن نخلي مثلا مايترال فالف ديزيز فيسيشن، والاورتيك فيسيشن، والبروستاتيك فالف فيسيشن ثانيه.
هنعملها بطريقه براكتيكال اكتر.
مش قادرين نستوعب، والحاجه دي ليها علاقه بال
الو
لايف براكتس بتاعنا دي باي دي.
لا احنا هنعرضها بطريقه براكتيكال في صوره كده، يعني questions already prepared على كل الجايد لاينز، وهنعرضها على اكتر من حاجه، mitral, aortic, prosthetic valves وهكذا. وبرضو جولييت ومينا وبرضو في حد تاني هنكفر كل اللي اتقال النهارده، لان فعلا انا بحيي جولييت على المجهود الكبير جدا جدا حقيقه على يعني انها تحضر هذه المجموعه الهائله من السلايدز وتكفر كل الجايد لاينز. ده مجهود كبير جدا بحيي عليها الحقيقه. فان شاء الله هتفق مع مينا وهنقول ايه البلان في المرتين الجايين. وانا بقول ان الحضور هيبقى اجباري للنواب والمعيدين، لان دي جايد لاينز هي البراكتس. يعني انا مش فاهم هم اللي ما بيحضروش دول يعني ازاي بيتعلموا. يعني دي جايد لاينز جديده 2021 بتكفر كل البراكتس اللي بنشوفه كل يوم في الفالفر هارت ديزيز، فلازم يبقى عارف النيو ريكومنديشنز وعارف الجايد لاينز وعارف كل حاجه.
النواب كمان البوست جراديويتس اللي معانا
طبعا
خلاص بعد كده لما بنيجي نسالهم في الامتحانات في الهارت ديزيز بنلاقي اجابات سيئه. فكل طبعا. ده الحقيقه هيتحسب عليهم، وهتبقى في مسج واضحه للبوست جراديويت بتوع اسم القلب ان عدم حضورهم ده هينتقص من تقييمهم اثناء امتحان الماجستير او الدكتوراه.
تمام خلاص اوكي دكتور محمد، ان شاء الله يعني هنرتب للفالفر هارت ديزيز جايد لاينز بالطريقه اللي احنا قلنا عليها. بنشكرك طبعا على يعني ان انت اديتنا من وقتك وشرفتنا في الجورنال كلاب النهارده.
انا بشكرك وبشكر جولييت الحقيقه والتيم، مجهود جبار، وباذن الله احنا مستنيين الجورنال كلاب الجاي باذن الله
ان شاء الله. شكرا يا جولييت، شكرا يا مينا، شكرا لمحمد ثابت والحضور جميعا كلكم. شكرا. مع السلامه.